Hello everyone and welcome back to the HP Leader YouTube channel. It's been an absolutely fantastic day so far, and this session in particular has been requested multiple times. It's session 5 on long COVID kids and long COVID in older adults. So I'm just going to ask by asking the panel to introduce themselves one by one. We are going to dedicate a minute's silence, national silence here if you are in the UK. And Dr. Ian Frayling is going to just say some words leading up to that. So just to give you advance notice, we are going to interrupt one of the sessions just for a minute's silence at 3 p.m. Sammy, can you introduce yourself, please?
Hi, I'm Sammy Mcfarland. I'm the founder of Long COVID Kids.
Thank you. Emma.
I'm Dr. Emma Vardy. I'm a consultant geriatrician and clinical dementia lead at Salford Royal Foundation Trust. I also work with various different groups in Greater Manchester, and I work as chair of the Dementia Specialist Interest Group for the British Geriatric Society.
Thank you. And last but not least, Ian, who is co-chairing this session with me and is going to lead on the questions. And some of you may have already seen him very active in the YouTube chat already. So Ian.
Yeah. Day 410 for me. I'm in a good phase. I'm on day 22, but I've had 2 lots of 18 days when I crashed within 2 hours. So I'm under no illusions. And I think that's part of psychological pacing. You hope for the best, but expect the worst, and you'll be a bit better than you were.
Thank you so much. Now we're going to go straight over to Sammy for a presentation. Now Sammy is on a holiday, a very well-deserved little break in a camper van. So I'm so chuffed for you being here. So please just excuse if there's anyone that interrupts our session. We're just going to go with the flow today. So thank you, Sammy.
Can you see my screen? I've shared my screen.
Perfect. Looks great.
Okay, great. So thanks very much for having me today. So I'm just going to talk a little very briefly about what Long COVID Kids is. We are a support and advocacy group, and we currently support 2,600 children via our Facebook support group, and we have children mostly from the UK but also from around the world, and we welcome all families from around the world to join us. And we've been raising awareness now since the autumn, when we launched our original video on YouTube. You can find it on our YouTube channel, Long COVID Kids, and it really explains about the challenges that we were facing, trying to raise awareness that children get long COVID too, and that the children were presenting very differently to the adults in their symptom presentation. So which children will get long COVID? That's the million-dollar question that we don't really know at the moment, and we're hoping that research will tell us. But what we do know is that any child that gets COVID-19 can get long COVID, and it doesn't matter which presentation of COVID that they have. So it could be that they have an asymptomatic presentation, it could be that they have a typical presentation, or it could be that they have symptomatic presentation, but they can still go on to get long COVID. And it isn't a linear journey between the two. It can look very different for lots of different children. So some children have what we term as a short recovery, or in a short apparent period of wellness between weeks 2 to 6 before they then develop the long COVID symptoms. Other children have consistent symptoms right the way throughout, from their original infection through to long COVID, and some children get COVID and then obviously go on to recover and don't develop long COVID. So really, we call it the long COVID web. You start with COVID infection, and unfortunately we don't know what the outcome will be. So the only way that we know to avoid long COVID is to avoid COVID infection. What does long COVID look like in children? So we have done a survey in our group, and the information that I am going to present to you is from that survey. And really, we like to think of long COVID as the top 10, but there are over 100 symptoms that families reported to us when we have done our survey. And you can find those on our website, longcovidkids.org, and there's a lot more detail on there. But for today's presentation, I want to focus on the top 10 symptoms. And I think it's important because we often hear about the classic symptoms that adults present with, being the cough, the loss of taste or smell, fever. And it's not so often that children present with these. They do sometimes, but not always. And really the gastrointestinal issues are the ones which most families report to us as being the symptoms that children present with when they have COVID, but then also through long COVID. So let's look at the top 10. Gastrointestinal issues is the first, the most prominent symptom that's reported, followed by chest pain, and then headaches, fatigue, joint pain, sore throat, rashes, dizziness, mood changes, and nausea. And nausea may or may not follow with vomiting, but I couldn't find the best image for that. So that child is vomiting, but some children just experience nausea continually all day, every day, which is extremely debilitating, distracting, and very difficult for them to then function in their everyday activities. So some of these symptoms in isolation you might think, well, that is not too bad, you know, a bit of sore throat, for example. But if you've had that for 365 days already, it really is starting to impact your life quite dramatically, and in terms of the way that you can play, that you can learn, that you can develop. And these symptoms can really affect children in a very dramatic way, even though in isolation they may seem not hugely radical. They are present in that child's life 24 hours a day for most children, or they may come and go. And if they come and go, relapsing and remitting, it can be difficult for parents and for carers to spot that symptom until it's been there for a very long time. And this is one of the reasons why we feel many children are not being diagnosed early on. Because, if you've got a child that's got a bit of a tummy ache and they're complaining about that on and off, and perhaps you see a doctor, perhaps you don't, and then maybe in 2 weeks time they're complaining about a sore knee, and that's sort of there for sometimes and then again not, and maybe you see a doctor, maybe you don't, and this is really how it's quite complex to spot in children, we feel, and one of the reasons that we really think that there needs to be a lot more awareness around when to test a child, because if you don't have that original PCR test that you can get at the beginning when you have COVID, it's very difficult then to sometimes get the diagnosis of long COVID, and when these symptoms can be coming and going, and sometimes presenting in isolation and sometimes presenting in clusters, and also in the intensity that they present. So sometimes the rash might be one spot on a finger, and other times it can be completely covering a child's body. So this is one of the huge challenges that we face. So highlighting the symptoms that children present with in COVID is something that we feel really passionately about, and we feel that there needs to be a much clearer awareness campaign around that to help families identify COVID earlier on in children, and the importance of getting a test to avoid misdiagnosis later on of long COVID if they end up with long-lasting symptoms. So those are our top 10, more information on our website. So I just wanted to have this slide in and do a little bit of myth busting, because we regularly attend meetings and webinars and hear a lot about the fatigue that comes with long COVID, and children do get that. It is a prominent symptom that children present with, but it is not the only symptom. There are many, many symptoms, and one of the strong prevalent symptoms in children are rashes, and the rashes can look very different, and there's a wide range of them, and I don't pretend to be a doctor, but I am showing you a variety of rashes that children and families are reporting in our group following COVID infection, and they are saying that they've not had these rashes ever before, so they are definitely post-COVID infection. And if you look at the one in the top left, which looks a bit like the molluscum contagion, it's those kind of little round sort of lumpy bits that children can get. I remember my child had them in primary school, and lots of children seem to get those, particularly the children that have had long COVID for a very long time. We're seeing an increase of prevalence of that particular rash. Whether it is molluscum, I don't know, but it looks very similar. The red eye, that's another symptom that children often present with. And then going across the top of the page, if you look at the horrible lesions on the girl's knee and then on another girl's face, these are two different cases, but the children had very similar rashes, and one of the children was actually admitted under the watch in a children's unit for over 72 hours because they thought that she was self-harming. And it wasn't until the medical staff witnessed the increase of rash on her body during that stay that they then started to take it more seriously and look a bit deeper into her symptoms. And we've now had a second child who's got the same presentation. And of the first child, they found they did some swabbing of the lesions, and they found COVID in the lesions. So that's something new and interesting, and also very uncomfortable, very painful. And that girl's actually been treated with MABS, which is a cancer treatment, and she had it 4 weeks ago and the rash healed, and now unfortunately it's just starting to come back. So we're following that case with interest. Moving across the top of the page to the very bright red tongue there, I've popped that one in because it is a symptom we see in children with long COVID, but we also see the symptom in children with PIMS, which is the pediatric complication of COVID infection, which requires urgent medical attention and can present in the first 2 weeks usually of original infection, and that is something that is treatable, and the child needs to seek medical advice and often is hospitalized for. But the reason I've got it in this slide is because it is a symptom that we see a lot in long COVID, again, particularly in the children that have had long COVID for a long time. And it presents like a strawberry tongue with white pimples, and obviously looks like a strawberry, hence the name. And then just some of the other rashes underneath, and you can see that they are very different, and have come on since COVID infection. And then the toes, COVID toe, which is purple digits, can look like chilblains and can get misdiagnosed as chilblains. Sometimes they split, sometimes they don't. They can be incredibly painful to the point that children can't wear shoes, they can't walk on their feet. Some younger children, parents are reporting that the children have reverted back to crawling on their hands and knees to keep their feet off the floor. And again, it seems to can come and go. We're not seeing it so much in the initial infection, but it seems to come out more 3, 4, 5 months down the line, which again is interesting to us. And in the cohort of children that were infected, have now been ill for 9 months and plus, they seem to be getting the COVID toe developing or resurfacing. So again, that's interesting to us anecdotally. And then along the bottom there, the sort of a variety of different rashes, the fingers, and then the young boy with the dark purple ulcerations on his tongue. So just lots more than fatigue to look out for. So I'm going to take you through a couple of case studies, or examples of case studies. This is Grace. Grace had a distorted taste, smell, and was unable to eat back in June last year. By July, she was diagnosed with parosmia, distorted taste and smell, and she had become very low in weight because she was unable to eat. All her food smelt of rotting meat, and some of her favourite foods that she would normally tasted of other things, and made her sick. By September, she had chronic fatigue, rashes, pains in joints, muscle weakness, bruising, dry eyes and lips. By October, she had an ENT ENT referral. Her MRI was clear, but she developed postural orthostatic tachycardia syndrome. So she was intolerant of standing up. She was very dizzy, and she had severe nausea. By November, she developed a malar rash, felt hot, was unable to regulate her temperature, and started to lose her hair. By December, more headaches, much more severe headaches, an overactive bladder, emotional outbursts, and started talking about wanting to die. This was extremely distressing for the family and for all families in the group, as we were following Grace's case and trying to support her. By January, she'd developed OCD, intrusive thoughts, vocal and motor tics. So she was swearing, she had involuntary movements, and she was emotionally and physically drained. She was utterly wiped out by the constant tics that she was exhibiting. She's had a couple of courses of different antibiotics now. Some help temporarily, some haven't. And very recently, she's been diagnosed with a tic disorder, which they said will become Tourette's after a year of onset, as well as the OCD. So we're following Grace's case with interest, and her mum is now getting some support, but she hasn't had any support really up until this last month. And Grace went from a very happy, normal, healthy, active child to having really significant emotional outbursts and a very sharp change in behavior. And unfortunately, her school haven't been able to welcome her back because they want special measures in place before she's able to return, for the safety of Grace and also for the other children. And so this is causing a lot of issues because the schools don't really know yet how to deal with long COVID. And so she's not been able to return with her peers, which is obviously upsetting and isolating for her. So parents reported a significant prevalence of neuropsychiatric symptoms among their children with persisting symptoms. So this comes from our second survey. In more detail, parents reported lack of concentration, 60%, difficulty remembering information, 45%, difficulty in doing everyday tasks, 40%, difficulty processing information, 32%, and short-term memory issues, 32%. These are significant changes in their child's health. And we do have that full clinical review on our research page of our website if you'd like to read more information. It is self-reporting from our group, and it does look at a wide range of mental health and activity levels in children. 510 children were part of that group. So I'm going to talk to you about Manny. Manny's 12 years old. I've chosen these two cases because they are very different, and I want to just highlight the wide range of symptoms that we see in long COVID with children. So Manny started developing cold-like symptoms, headache, sore throat, runny nose and fever back in September. This was followed by cough and a burning chest. Later in September, he was taken to A&E with breathing difficulties, a continuous cough, and was given a steroid inhaler. 2 days later, all the skin on his feet peeled off in layers, and a further 2 days later, he was taken back to A&E with severe pain in his arms and legs. He was unable to move his head. He had bloods and was sent home and told it was psychosomatic. On the 27th of September, just a few days later again, he was paralyzed from the neck down, unable to walk or talk. He was screaming in pain, but he couldn't communicate verbally. He was unable to tolerate clothes or to be touched. He had oromorph, which was unhelpful. He had more bloods done. He had a psych referral, but that never happened, unfortunately. And he was forced to do physio. And his parents used the word forced because he was pulled from his chair. He was screaming in pain. And eventually, just a couple of days later, his mum decided to self-discharge because she didn't feel that treatment was helping him in any way. It's 7 months on since that. Manny is now able to shuffle around in the house, but he uses a wheelchair when they go out. And he was in a wheelchair for a very long time before being able to get back to shuffling around in the house. His symptoms have been cold sweats, diarrhea, bright red cheeks, severe headaches, feeling sick and dizzy, extreme fatigue, heart pain, chest pain, stomach pain, extreme hunger and then no appetite. And that's one we hear a lot from families. Visible broken veins, feeling weak, emotionally low and anxious, hallucinations, skin peeling, bloodshot itchy eyes, cold hands and feet. He's had a number of tests which have been inconclusive, including ECG, chest X-ray, MRI, abdominal scan, cardiology referral, and bloods. As yet, Manny hasn't returned to health, and he used to be captain of his team, so he's really looking forward to getting back to be physically active, but that's not yet possible for him. And that's true of many children in our group, which I'm going to talk to you a little bit more about. So this slide shows the reporting statistics found from our clinical characteristics, activity levels and mental health problems in children with long COVID. We worked with Danilo Bonzero, I'm not sure if I said his surname right, I hope he's not listening, and Farhan and Daniel Mumblet, who are all well published researchers, paediatricians, and they helped us pull together our information. So we had 510 children, and we gave them a survey to fill in, and with multiple choice and some with open-ended options, and then took that data, and then people much more cleverer than Fran and I looked at it and analysed it for us. So 56% of the children that in our survey were female, and this has been consistently found, I believe, with adult groups and with other surveys too in children, other research in children. And the mean length of time of persisting COVID symptoms was found to be 8 months, and actually that would have been a lot higher because many of the children in our group have had symptoms now for 12 months or more, but just after Christmas we had a high level of influx to our group of children who had recently got COVID, so that pulled our figure down a little bit more, and then only 4% of the children had ever been hospitalized. And I think that's really important to think about quite a lot, because the ONS data, or the government data that we hear about, where they say that children only get mild symptoms and that not many children have been affected, they're really talking about the children that have been hospitalized. And so it's true to say that most children do get mild symptoms, but we would really like people to be more curious about what happens next, and it's the what happens to children 6 weeks plus after their infection that we would like to have much more attention on, much more awareness of, and much more research into. So if 4% of children were hospitalized, and we think about the figures that are talked about in the media, then we can easily see that clearly there are a lot more children that are not hospitalized but experiencing significant changes from COVID infection. And then the mean age from our survey 1 and our survey 2 was 10 years old. So we really think that there needs to be a lot more awareness in the primary schools, and also we as a group, although we're not huge fans of masks, we do think they're actually necessary, and we would urge everyone with primary school age children to seriously consider mask wearing, whether the school it says it's necessary or not. So 49% of children in the survey had periods of apparent recovery before symptoms then returned. So that again is interesting to us, because often people are talking to children or families 4 weeks after their initial infection, and then if they're feeling well, they think that they've recovered, and actually it's often about 6 weeks onwards where these long COVID symptoms start to reoccur for many children. And 30% enjoy occasional activity, but usually have an increase of symptoms after. So this was really where we were looking at the activity levels. Could children go back to doing what they used to do? And most children haven't been able to. In fact, only 10% of children that we surveyed had been able to return to their previous activity levels. And that's hugely significant. For some, it's very much being housebound. For others, just being able to get from their bed to the toilet might be their activity. It might be having a shower. It might be sitting up to eat their food at a table. So really very big lifestyle changes for these children. And then I just wanted to touch on the effects of children since COVID-19. So it really affects every single aspect of their life, with the most significant changes in energy levels, mood, sleep, appetite, and cognitive function. And again, you can read more details about this on our website on the research page if you wish. And we are interested in activity levels in particular. And one of the questions that we asked in our survey was, during the first 6 weeks after infection, did the children participate in some level of activity or not? And 51% of children did, and 43% did not. And we wonder what would happen if those children had just rested in those first 6 weeks. Would the outcome of their recovery be different? We don't know, but it's something we're interested in and to see research done on. And then the neuropsychiatric symptoms. So this is an area, again, of interest to us because it's something that's regularly reported in the group, and it's something which is going to be ongoing seen in schools as a challenge in returning to education. So in terms of, from an educational perspective, it's going to require a lot more thought about how children return to school, how they're supported in school with long COVID. In particular, the concentration issues are significant, with 26% of children having reported no previous issues before COVID infection. So what works, what helps? I can only give you anecdotal information, obviously, but rest is the one thing that all parents and carers of children in the group agree on, that is really, really important. And it's the biggest question that we get asked when we get new members join the group. How quickly can my child return to sports? You know, should I be getting them back to school? So I really wanted just to spend a few minutes talking about this. Physical, intellectual, social, and emotional activities all require energy. So when we think about rest, it's not just sitting still in a chair and then doing some homework. It's actually switching off to all of those things if needed, and really thinking about how much energy is required to do simple things like brushing your teeth, getting dressed, having a shower. You know, all of these things require energy. So they are part of the energy drain. So therefore, those energy resources need to be diverted into recovery. And so if we can reduce some of those things and perhaps not shower quite as often in the initial phase, if that feels appropriate, that might be helpful. So we don't have any great guidance at the moment, so we're doing our very best in group. And what we are suggesting is that in week 1 to 6, we're allowing as much sleep as required for children who are resting. And there was a lot of confusion in the early days about how much sleep the children should be having, because I think, you know, we were told that after 10 to 14 days, people can go back to work. So therefore, children were expected to return back to school after that time frame. And that really wasn't working. We were seeing lots of children crashing and having a lot of problems in school and deteriorating in health. So we suggest 1 to 6 weeks is really, you know, when you're fighting the infection and you're recovering from your initial COVID infection, to keep activity levels very low and sleep as much as required. And then in weeks 6 to 12, allowing sleep as needed, providing it does not disrupt nighttime sleep. So that's really a fine balancing act, and it varies dramatically for all children, and so everyone needs to be treated as an individual. But again, keeping activity levels low. We say that because lots of children have gone back, that have returned back to sports and higher levels of activity, have then gone on to report significant chest pain. So in the absence of other guidance, then it's seems appropriate to keep activity levels low, but testing tolerance with short appropriate activity sessions that do not induce symptoms. One of the diagnoses that a lot of children have had is postural tachycardia syndrome, POTS, and it can be life-altering and debilitating. So essentially, it's almost just becoming intolerant standing up. And for people that's affected, it's when the body is unable to adjust to gravity, and symptoms can include dizziness, palpitations, lightheadedness, fatigue, sweating, nausea, fainting, headaches. And so, as I say, this is something we see a lot in the children. Things that have been reported to help are electrolytes, compression socks or tummy wraps, which are easily available, and also lifting the head end of the bed, just putting some books underneath, things like that, and encouraging children to go slowly from laying to sitting and sitting to standing and sitting back down if needed, rather than kind of get up and rushing off. So things like that can really help. Sleep hygiene, so looking at how we can reduce screen time close to bedtimes, regular bedtime, regular wake time, and ideally getting outside and just sitting in the sunshine, sitting in the daylight, even if it's not possible to actually move around in the garden, just sitting on the back step of the house, something like that. Nutrition, lots of families report low histamine diet is helpful, and some reporting low sugar, gluten, dairy diets are helpful, and supplements are widely discussed in group, with lots of families using different supplements. Well-being, I'm a huge advocate for well-being. I'm a mindfulness coach and well-being coach by trade, or previously was before I got long COVID myself. And breathing exercises are hugely beneficial, both in helping with relaxation and in helping with symptom management. But also, one of the things that lots of families are finding helpful are Epsom salts baths, or simply soaking feet if you can't get in the bath. So we don't know what works yet, but these are the things we found helpful, and we hope that sharing them today will be helpful to you. Thank you very much.
Thanks, Sammy. And I mean, I'm so grateful for you to talk, because there's so little out there. There really is so little. And I know maybe we need to do a whole session on this, a whole couple of hours on this. So I'm so grateful for your time. And we're going to go straight over into Emma's presentation. And then, like I mentioned, Ian is going to introduce the minute silence and then lead off with questions after Emma's talk. Thank you so much, Emma.
Sorry, can you hear me now and see my slides?
Yep, we can see and hear. Thank you.
Okay, so yes, I'm a consultant geriatrician and going to talk about long COVID considerations in older people, which has come from, I guess, sort of accidentally becoming involved in long COVID clinics, which I'll talk to you about in a moment, and what my role has been in them. So, sorry, I'm just struggling to move my slide on. I do apologise. Okay, so some considerations around older people and COVID. I think it will not come as a surprise to anybody that older people experienced greater severity of disease and high mortality rate during the waves of the pandemic. Many of my colleagues worked on the acute COVID wards looking after older people, and noticed during their inpatient admission, let alone at any point of follow-up, psychological, cognitive and physical deterioration at point of discharge. There's been, I think it's important when we're talking about older people, as a geriatrician, we champion the needs of older people and will put the opposing view when there's evidence of potential age discrimination. And there was some risk of that with things like clinical frailty scales being used in part to make decisions about intensive care unit admission. And older people are particularly at risk of long COVID in part because they have multiple comorbidities, or more likely to have multiple comorbidities before contracting COVID, but also some of the conditions that they may have already will make them increasingly susceptible, such as background conditions such as dementia or Parkinson's disease. I think it's worth just remembering how people present with COVID, and it will make more sense as to why I'm reminding viewers of this. And one of the areas that I'm going to focus on in some of this discussion is around the frequency of the presenting symptoms, and the fact that relatively early on in the first wave, altered consciousness, confusion, as geriatricians we would call it delirium. And it was interesting hearing Dr. Zandi speak about terminology in terms of encephalopathy, and actually that was raised during the pandemic as to this issue of terminology, and there actually have been international multi-organisation working groups that have published on this, and generally accepted would be that delirium would be the term for the symptomatology, whereas encephalopathy would describe better the underlying pathophysiology. But I think it is a bit specialty dependent as to what terminology would be used, and certainly in my specialty, and in terms of screening for delirium in at-risk groups, we would tend to use the term delirium, and it was picked up partway during the first wave as being a key symptom, and which was added to the potential presenting features of COVID during the pandemic, and these are the references at the bottom of that slide. And it's helpful to just talk about what we know about delirium pre-COVID. We know that delirium will enhance cognitive deterioration. You know, as people age, their cognition will generally gradually deteriorate. But if you have a delirium on top, as illustrated by this dotted red line, your trajectory will be a steeper decline. And we also know that delirium makes dementia worse. So if you have a background diagnosis of Alzheimer's disease, your rate of decline is at twice the rate as if you hadn't experienced delirium. So this is what we knew already. So what about older people and long COVID? Well, it was really interesting seeing some of the presentations this morning around epidemiology and some of the studies that have been done. I was sort of looking in terms of putting this presentation together about where age plays a role. And these were a couple of studies that actually I took from a colleague who has written a piece for the British Geriatric Society. And this is a study by Tenford et al. So it was last year, about features of not returning to usual health. And actually, as you can see, I mean, it only goes up to 50. And I noted the descriptions of how different people would describe age. I mean, my description of old age, the patient population I would generally look after would be frequently over 80, but actually we would maybe use a cutoff of 65 for certain assessments such as delirium screening on admission to hospital. So as you can see, it's a relatively sort of younger age cutoff, but age was still found to be associated with long COVID, and also the number of comorbid medical conditions. And also as geriatricians, we would also see younger people with multiple comorbidities and complexity and be very patient-centered. And so may well see some younger people as well. This is a slide about a study from Sudre et al. From a London group, including a colleague, Claire Steeves, and this was from the symptoms from the Zoe app around self-reported symptoms post-COVID, and you can see the graph on the left is the duration in days after which people were reporting some of these symptoms, and you can see that there was an increase in reporting of symptoms with age, so in the over 70 age group. And although you can't see and you haven't got the key for what all of these different things stand for, DE, delirium, is the top feature, and it just shows you sort of the range in terms of days as to how long some of these can go on for. Thought it was an interesting point that somebody made earlier about the time of presentation. And I think that's, again, another important feature about when people should be followed up, particularly around some of their cognitive impairment, is, as per some of the general guidance, 6 weeks just too soon, because delirium will recover in many people, but it's those people where it goes on for longer that you would want to be following up. And it was also noted that people experiencing more than 5 symptoms at the start of the illness, that predicted long COVID. So how are people detected? So through various different routes, and I guess some of our routes for referral to the long COVID may be skewed towards certain age groups. So, for example, the route through primary care in national guidance, it's noted there should be a distinction between long COVID and existing long-term conditions. Can actually be quite difficult sometimes, and being very patient focused and taking a clear history as to when certain symptoms appeared and have they particularly been worse since experiencing COVID related illness. I think for hospitalized patients, many systems are set up in terms of the respiratory safety net. So if people had moderate to severe disease, had x-ray changes, they would have a repeat chest x-ray at 12 weeks. And actually that's the group where I'm seeing some patients, not because I'm a respiratory consultant, but because the process in my organisation has been that the discharging consultant should follow up with X-ray their patients. So I'm following up people for my colleagues who are on the wards, whereas I work more in the community now, and also in outpatient services. Do you want me to stop now, Ian, or shall I'll just finish this slide quickly? And these have been reiterated in the various guidelines through NICE in terms of managing the long-term effects of COVID, and I'll just pause there.
Thank you, Emma. Yeah, we've got a couple of minutes to go. So how do you want to play it? I guess it'll take more than a minute to do that slide.
I'll quickly describe this one and then we'll,
okay.
Sorry, it's difficult to know quite when to stop and I don't want to overrun.
Yeah, judging time as well. Yeah,
so I think this is just an overview from NICE and RCGP and SIGN guidance. And again, you can see there's particular time points included in it. Relying on some people self-presenting, you have the respiratory safety net at 12 weeks. And I'm just, as a geriatrician, concerned that some of the symptoms and features of long COVID that older people may present with may present outside of this framework. And important also to show that many kind of frameworks would include digital and technology. And actually my experience through trying to use virtual platforms with older people is that many people don't actually have smartphones, or at least not in the area that I work in Salford. And again, we need to be mindful of how people are filtering into to services when they don't have some of the that access available. I'll pause there.
Okay, thank you, Emma. For those outside the UK, you might not realise that today is the funeral of His Royal Highness the Prince Philip, Duke of Edinburgh. He happens to be, or happened to be, the patron of a sporting club that I am a member of. So I do have a bit of a connection there. So we will observe the UK's national 1 minute of silence at 3 o'clock. And we remember his devotion to duty and service, which is an example to all. So I will mute myself. So, Emma, perhaps you'd care
Okay,
to...
I shall continue. Can you hear me still?
Yes, fine, thanks.
Can I have a nod from you, Ian? Yes? Yeah, great. And seems very fitting that we just took that moment whilst we're talking about older people as well. As we know, Prince Philip was 99 years old. So moving on to my next slide, which hopefully will work. Apologies for this, just seem to have struck a technical hitch. Just going to reshare my screen. Sorry, it seems to have paused. Right. Hopefully that will work. From current slide. Right. Great. Okay. So I've been interested in who is followed up. I'll talk about my own personal experience in a moment, but I was looking for studies that were out there around some of the demographics. And I guess this data is being collated and emerging, you know, as we work through things at the moment. I looked at this study by Arnold et al. From 2020, and initially I thought, gosh, well, you know, I won't include that because those patients, you know, really quite young, you know, up to 71. But then I felt that that was really important to show you this, because perhaps it is highlighting that older people, I mean, many will have passed away. Maybe they're not presenting. Maybe they're not picked up through the safety nets. Maybe it's the specialties involved in some of the long COVID clinics. Just worth considering that. I asked yesterday, I've been working with the Greater Manchester long COVID group that's chaired by Dr. Jenny Hoyle in Greater Manchester. She's a respiratory physician. So these numbers may look relatively small, but just to say that this is from a SITREP report, it depends on data that's uploaded. And I looked at the various age cutoffs, and the numbers in the middle part of the table are the total numbers of people who've been followed up in long COVID clinics. And the column on the right is the percentage. And as many will be familiar to many of you, the most sort of common age of people who are being followed up in long COVID clinics are those in more middle age. But if you take older age of 65 years and over, that's still around 1 in 5 people. But my suspicion is that there may well be more for different reasons, and I'll come on to those in a moment. So I work at Salford. It's a tertiary centre in the northwest of England. And the long COVID clinic is an MDT, and it's led by Dr. Nawar Bakley, one of our respiratory physicians. So I think a slide has missed out there. Sorry, in terms of the MDT, who's involved are respiratory, cardiology, we have a chronic fatigue service, including psychology and one of the endocrinology consultants, neurorehabilitation, mental health, community therapy services, and myself as a geriatrician. Some of the symptoms in older people that seem to be emerging are, as many people have shown, fatigue, anxiety, low mood, cognition, myalgia. Surprisingly few people with ongoing respiratory symptoms of the small cohort that I've been following up so far. And I say anecdotal postural hypotension. And what I mean is that I know from colleagues who were looking after people who were stepped down from hospital to intermediate care units, they saw a lot of postural hypotension. I'm not sure that they had the measures for heart rate at the same time to know whether it was POTS, but I understand that they were starting medication for that, including midodrine. But I know that people are presenting with other cardiac type symptoms, including dizziness, postural hypotension, some diagnosed with POTS to cardiology services. And what's great about the MDT is it feels like quite a rarity these days to have pan-specialty MDTs, you know, with sort of the loss of some of the grand rounds in some organisations. We're learning from each other all the time. I'm particularly learning about long COVID because it's such a new area. So what I would say is that I'm using both old skills and new skills. So, I mean, as a geriatrician, we're one of the few generalists in terms of medical specialties, and in addition to GPs and primary care that still exist. So we have something called the Comprehensive Geriatric Assessment, which is very familiar to my specialty, which includes physical, mental health, cognitive, psychosocial aspects, and we're very much used to diagnosing multiple conditions or looking after people with new symptoms in the background of multiple conditions. I've actually inherited a falls and syncope clinic from a colleague, so I've been building my knowledge and experience around orthostatic hypotension, dizziness. But actually I'm building on that knowledge further from learning from cardiology colleagues. So I know that I need to be aware of how to diagnose and to recognise POTS and what appropriate investigations to order. I think one area that that I'm skilling myself up around is chronic fatigue. I mean, the term deconditioning has been around in circles of people looking after older people for some time. There were various campaigns in UK-based hospitals about people getting up and keeping moving, and we know that people who are frailer would be more at risk of deconditioning and being more dependent on leaving hospital. And actually it's interesting, just comparing to what Sammy said, we would very much be encouraging people to get up and keep moving and keep the activity going, such that they don't lose muscle strength and such that they that people don't lose function. And I think the other thing, I mean, my one of my special interest areas is cognition and dementia and delirium, but so far some of the people that I have seen, and it's, you know, a relatively small number, are presenting with quite different symptomatology to the typical types of dementia with certain typical features. So one person presented with specific word finding difficulties. Another person, it was difficult, they had performed very poorly on cognitive assessment. I used the Adam Brooks cognitive examination, but had significant overlay from anxiety, and actually I think there was significant impact, still working this particular patient up, but significant impact from bereavement, where a relative actually died on the same unit as they were an inpatient. And there's also many people talking about having lost friends to COVID, and also complex grief experience by people not being able to attend funerals. So sorry, I can't quite see due to the control panel at the top, the very top of my slide, but this is 6-month outcomes in survivors of COVID, a retrospective cohort study that's just come out through the Lancet Psychiatry, and was particularly, sorry, I can't quite read the top bit, I think it's neurological outcomes, but risks were certainly greater in those with severe disease, and you can see some of the demographics. Of course, this was a younger population, as you can see from the age. Interestingly, the patients with encephalopathy, I think presumably because they were admitted through ITU, but many of them were likely I would frame delirium. And actually I thought these two graphs were really interesting because it really just replicates what I came back to at the beginning about the outcomes for delirium. So the graph on the left, and also that link between delirium and dementia, the outcome on the left, comparing people with COVID-19 compared to other respiratory tract infections such as influenza, the incidence of dementia being higher. So perhaps there is something that's different around COVID and the impact on the brain and the pathophysiology, and maybe you know, the impact of having a delirium. And you can also see the graph at the bottom right where there are different lines and showing that people who had an encephalopathy or a delirium were at the highest risk of developing dementia, which again just duplicates what as geriatricians and those who are interested in delirium already know. And actually 4.7% of people developed dementia through this method of detection, and the percentage, the incidence was much higher for people who had been admitted to ICU. I mean, I do query that a little bit because 6 months to make a diagnosis of dementia is quite a short time frame, but still concerning nonetheless. So some future suggestions for services. I think I found it very helpful as a geriatrician being involved in discussions around development of long COVID services and championing the needs of older people and how people are detected. I'm not aware that there are any pathways that would as a standard, follow up people who had experienced delirium. That's been something in geriatric medicine, or people's medical circles, that we've been talking about for some time. And actually, as somebody interested in delirium, we would recommend that people with delirium are followed up, or at least given some advice that if their impairments or memory impairment have not resolved after 12 weeks, that they seek further review. But that's certainly not standardized in terms of follow-up, such as the respiratory chest x-ray safety net. To consider the accessibility of those pathways, including if there is other issues around digital inclusion, to remember long COVID in the context of chronic conditions. And I think there's something about communication about symptoms of long COVID to look out for in certain specialty clinics, such as Parkinson's disease, and also sharing information with colleagues in mental health and memory clinics. To consider, are we detecting the anticipated numbers of older people that we might expect? And is there a bias because of the way they're being detected? To consider who is around the table. I haven't heard so far, but I'd be really interested to know if other people's MDTs have a geriatrician. I saw in the chat there were issues about having a doctor full stop, let alone what sort of specialists they are. What is happening in terms of me referring people, I follow people up who are picked up through the respiratory safety net, and then identify people to go on the long COVID MDT list. And then I have the opportunity to be able to discuss those people with those other specialists. And just to come back to how is delirium followed up. So I'd encourage you, this is a really excellent blog by a colleague, Dr. Sanandan, who is a consultant geriatrician at Barts, which I found really insightful. And there are lots of other resources on the British Geriatric Society website. And finally, just to say that there is research going on in this area, looking at rehabilitation after COVID-19. So thank you very much. And I hope I haven't overrun with various pauses. No, I think I'm spot on. Thank you.
Thank you, Emma. Yeah, that was spot on and fine. We've got a bit of time.
I can't hear you.
Oh, okay. Oh, you can't hear me?
I can hear you okay. Do you want to start with the questions for Sammy, Ian? If
yeah.
Sammy's
Is she there?
I think she's just on site. Maybe, yep, she's here.
I'm here, yeah, I'm here.
Is she still in her car? It looked a bit like a garage, didn't it?
No, I'm sat by the beach now because the signal's better.
Oh, okay. Well, very nice. So what struck me about the long COVID in children was how similar it is in adults in many respects, but there are evidently distinctive features that are common in the children, especially the rashes. I wondered if you'd like to comment on that further.
On the rashes?
Yeah, the features.
Sorry, I don't know if I lost you a bit there.
Yeah. What struck me was that adults clearly have many of the features in common with children, but there are features that seem to be particularly prevalent or strong in children, and the rashes were one of them.
Yeah, so it's
yeah. Unfortunately, you're dropping in and out. So I don't know whether you can or you want to try and get to a place with a better signal.
Oh, I would just move on to Emma. I'll try and mute Sammy from.
Really strange, because we're commonly advised that they are.
Oh, it's a bit like long COVID itself. You have good bits and bad bits.
Do you just want to move on to Emma?
I think we'll move to Emma and hope that Sammy can get a better signal. So Emma, you'd perhaps like to unmute yourself.
Yeah, yes. I can't see the YouTube chat. I'm intrigued as to whether this generated a bit of discussion.
it's all part of the digital exclusion, isn't it?
Yeah.
I'm at an age when, well, my hearing's gone for other reasons, but you know, I need devices with big letters. So I feel for those people at both ends of whatever spectrum we're talking about, who struggle to have access to anything, basically.
Yeah, I mean, actually, it's been interesting being involved in a few different services where there's overlap. So I was involved in stepping. So we barely paused outpatient services because we pretty rapidly moved to telephone. We tried out some of the digital platforms such as AccuRx, which didn't really work, and in many cases wasn't entirely necessary for older people. But I tend to triage people, so actually I'm doing telephone assessment in the first instance, and then working out those people that I need to see in person. And it just reminded me, actually, there was a couple of symptoms that I didn't mention. As I say, it's relatively small. I mean, some people have recovered amazingly well. Some of the people are younger because of the way the bed base was set up that I happen to be reviewing, which is quite amusing when I'm a geriatrician reviewing people in that, well, you're slightly younger than me, which I'm not going to reveal. But some of the people who've recovered, it's a little bit like, you know, sort of the generations that's probably just gone past, people who, you know, if they survived various illnesses, including, you know, sort of flu pandemics, then they're pretty stoical and have survived much. But other people have been really affected, and it's a small handful. And actually from this, it makes me realize I need to analyze that data. You know, it's sort of people publishing those data sets, but, you know, people describing it. I think listening to some of these talks makes me realize the spectrum of symptoms. So I did have a lady who was describing hair loss, also paresthesia in her fingers. And I think I've realized I, as a definitely not a gatekeeper, but as part of the pathway and the expectation, and because of the pressure that there may be on long COVID services, I need to work people up as much as possible, but also to remember that it might not be COVID, it might be their other premorbid conditions, it might be something else that may or may not be COVID triggered, but actually also to listen to those people. And I think also older people, I think many of them around, you know, the fatigue, the lethargy, some of the people that I happen to be following up, you know, I am asking, we have a structured performer, they will mention those things, but I think many older people might think, well, this is just normal, this is part and parcel of being older, you know, this is to be expected because I've been really unwell, but not necessarily.
Yeah, I mean, that I totally agree with that. I'm you know, a bit under the threshold of 65, but I know I've forgotten things that I had, like I was reminded on the chat just now that I'd foot dropped for a few days last year, and then after a few days when I was thinking I better report this, it goes. So all those sorts of things, and some of us here in Wales have been fortunate to actually be seen finally by a consultant physician, and actually seeing a human face to face and being told is so much better and kinder than you know, being seen by a leaflet or a phone call. I think, at least in the first instance, then you can give people the supplementary materials. But I think you have to be very careful about just assuming that because you've got a leaflet with small print on an app that works on an electronic device that was invented in the last 10% of your life, you know, you're ticking the boxes. So it struck me the other day also, when I was in a lucid phase, that if ever there was a disease that was designed for a general physician, it is long COVID. And so it struck me too about your comment about that you're one of the last bits of medicine that hasn't been so specialized, you've forgotten all the other bits.
Yeah. Although I guess we're specialized, but become specialists in that multi-morbidity.
Yes, you're a specialist in generalization in older people. Yes.
Yeah, but actually it's really made me query that distinction between deconditioning and chronic fatigue. So we're very lucky at Salford to have a chronic fatigue service. Right. So I've arranged sessions we have a psychologist who works with that service, Sarah Lowe. So I am looking up, and I've actually started doing some research myself, fatigue in older people, what's pathological, what would be a bit of slowing down and sort of natural fatigue as you get older. But I have had people over the years who referred with primary care with a multitude of symptoms where people don't fit into one particular box. And some people very specifically say, I have slowed down. I used to do this and I can't now. And there's some people post-Covert who are saying that. And so I am learning about things like pacing, what is proper downtime, watching television is not downtime. And also they have shared their resources, which are very chronic fatigue based. So I'm aware I need to be quite specific with who I use those with, but there are definitely some learning points, some general principles in terms of pacing and how to conserve energy, but to keep moving as well, which is really important in older people to prevent deterioration or onset of frailty.
I think that's really interesting and very useful to learn from somebody whose hospital has that kind of facility, in terms of that. And I would agree that the older you get, the more you ascribe things to, well, of course, I'm just getting a bit older, aren't you? Something tweaks or whatever. So that the signal noise ratio sort of suffers somewhat, doesn't it? Yeah. Rachel, how are we doing for time?
Thank you. Well, we have run over, unsurprisingly, but it's great discussion. Emma, there is loads of discussion in the chat, but we're going to move it over onto Twitter, and I'll definitely tweet some questions. I've put your handle in the chat, and obviously, Ian, you've been in the chat. We are having a short break. We will be back at past. So on my clock, it's 7 minutes, but on yours, it's probably a little bit shorter than that, but it is the last session of the day, so please do join in. It's our vocational rehab and return to work planning, which has been a highly requested session as well. So thanks so much to Sammy who dropped out, Emma, brilliant, and Ian, thank you so much for your personal insights as well.
Yeah. So 3:30 then.
3:30. 3:30, yes.
Right.
See you in a bit.
Speak up. I haven't got my aids in. 3:30.